right, now we're going to move on and we're going to talk about Chapter 28, the reproductive system. This is obviously going to focus on both the male and the female reproductive system. We're going to talk about the structures. We'll also talk a little bit about the hormones and how they interact with these different structures. So before we actually get into the individual systems, male and female, this is the only system that is not essential for the life of the individual. You can have a non-functional reproductive system and be pretty much just fine. However, it does affect other systems, and this is normally due to the hormones, okay? But again, hormone replacement and things like that can be done. The male and female reproductive organs are known as gonads. They produce and store specialized reproductive cells. These specialized reproductive cells are called gametes, egg or sperm. And they actually combine to make a new individual. These egg and sperm are produced through the process of meiosis. Remember from Anatomy 1, meiosis is where a cell divides not once but twice, and it halves the number of chromosomes. So in a human, it goes from 46 chromosomes down to 23, so that when an egg and a sperm fuse together, it goes back to the 46 that we need as a human. The reproductive organs also secrete hormones. These are the ones that play a major role in the maintenance of normal sexual function, but they also can play a role in other areas of the body. So the hormones are the main thing that causes potential issues in other systems, but you could survive without a functional reproductive system. So when we look at reproductive structures in general, they're called gonads. These are the organs that produce gametes and the hormones. There's also going to be a series of ducts that receive and transport these gametes, whether it's an egg or sperm. There's also some accessory glands where we're going to secrete fluids into these ducts. These fluids a lot of times are going to help the egg or sperm to survive in different conditions. And then of course there's also what we call the perineal structures, collectively known as the external genitalia, which is different depending on if you're male or female. So male and female reproductive systems are functionally different as well. The female produces 1 gamete per month, so it's only going to produce normally 1 egg per month. Sometimes 2, and of course if the woman is taking fertility treatments and things like that, it can produce more. Not only does it produce gametes though, it also is going to retain and nurture the developing zygote and baby. All right, so the female reproductive system has another job besides just producing the egg or the gamete. The male reproductive system is going to produce large quantities of gametes, actually going to produce about 500 million sperm per day. So it's going to be producing a very large amount of gametes, but that's its main role, is to produce those gametes. It's not going to nourish or retain the new individual that has formed due to the fusion of the egg and the sperm that's found with the female. All right, so we're going to start with the male reproductive system first. A quick overview of the male reproductive system. Remember, the gonads are the reproductive organ, and in the case of the males are the testes. There is a systems of ducts. This is going to be the ductus epididymis, the ductus deferens, the ejaculatory duct, and the urethra. There's accessory sex glands like the seminal vesicles, the prostate gland, the barotherial gland, or what we also know as the Cowper's gland, and several supporting structures like the penis and the scrotum. So we're going to begin talking about these structures. So let's start with the scrotum first. It's a cutaneous outpouching of the abdomen that supports the testes. Now this is important. It's important that the scrotum is located outside the body, and we'll talk a little bit more about that in a minute. So inside the scrotum there is what we call a vertical septum. It divides the scrotum into 2 sacs, a right and a left. Each sac is going to contain 1 testes. So inside the structure as well, there's going to be some special muscles. It's called the dartos and the cremaster muscles. These are going to regulate the testicular temperature required to make sperm. It's really important that sperm is produced 2 to 3 degrees below your body temperature, and so this is why the testes are found outside of the body. They're found outside to allow for optimum sperm production. So sometimes whenever males are having fertility issues, it could be because the scrotum is being held too high up to the body and causing it to be too warm, which could potentially cause sperm count to be lower. And this can happen if you wear like skinny jeans, tighty-whities, things like that. And so the whole point of that is to keep the scrotum at that lower temperature to optimize sperm production. This brings us to the testes, since they are located inside of the scrotum. It is a pair of oval-shaped glands, which we talked about in the a little bit in the endocrine chapter. Again, these are the gonads. The testes develop on the superior and posterior abdominal wall of the embryo. So as the baby is developing, these testes actually do develop in the abdomen just like the ovaries do. So this is why before a certain amount of time of gestation, we can't tell physically if it's a male or female baby. Okay, once we get past that point, back about 18 to 20 weeks, we can actually see that the testes have started to descend. We see the formation of the penis, and you can tell a male versus a female at that point. But before, they're located in the abdomen just like the ovaries are. They will distend though through some tunnels that are called inguinal canals. They're going to distend through these tunnels in the abdominal wall into the scrotum. Now, when we look at this, so the seminiferous tubules are where sperm cells are going to be made, and you'll notice them here in the picture. It's a lot of small tubules found inside of the testes. These tubules are lined with a lot of different cells. The Sertoli cells, which are the nurse cells, the Langding cells, and the spermatogenic cells. They're going to help with various stages of developing sperm. Remember, the Sertoli cells are the ones that can secrete inhibin. This is again to inhibit the release of follicle stimulating hormone if there's not enough room for any more sperm development. The Langding cells are also known as the interstitial cells. They're going to also secrete testosterone. With the testosterone, when it starts to be produced in larger amounts during puberty, it leads to the development of male secondary sexual characteristics. This is going to cause what we call the stimulation of anabolism, which is the musculoskeletal growth, where we see that the male's body looks a little bit different. Normally broader shoulders, thinner waist where it's more straight. We also see the muscle distribution starts to change because protein growth. Hair growth patterns will change too. They'll also get some hair on, of course, their face, under the arms, the genital area, but also they could be on their chest, their back, that sort of thing. We also see lowering of the voice and the development of their libido, which is their sex drive, and this is due to the presence of testosterone. Right here we have a picture of spermatogenesis, which is the formation of the sperm that takes place within the testes. Again, if you have the 14th edition of the book, this is found on page 1046. If you'll notice, you see the Langding cells here. Those are the ones that are going to produce the testosterone. You also can see there's blood vessels present. You can also see the Sertoli cells, which are going to be nursing the developing sperm. You can also see that you see the spermatogonium, the primary spermatocyte, secondary spermatocyte, and then finally we get into where we have the sperm, where the sperm's going to develop. Now, this is through meiosis, so we go from having one cell and it divides into two, and then it divides into four. So from each original stem cell, we should see the formation of 4 sperm. The sperm is not mature, though, however, until it develops into its 3 pieces, which has the head, the mid piece, and the tail, which you can see closer to the bottom of this picture. So when we look at spermatogenesis, the spermatozoa are produced in the seminiferous tubules by sperm stem cells, which are called spermatogonia. At the beginning of puberty, the anterior pituitary increases its secretion of those gonadotropic releasing hormones, and then that's going to cause the gonadotropic hormones like LH and FSH to start being released. Follicle stimulating hormone then is going to stimulate the Sertoli cells and increase the rate of spermatogenesis, which again is the formation of sperm. The LH is going to stimulate the Langding cells, which are going to give off and start secreting testosterone. Now, remember, when we talk about a lot of times those steroid hormones like estrogen, testosterone, so on, remember that their basis is cholesterol. So cholesterol needs to be present in the body, but it is going to be used a lot of times to synthesize these steroid hormones like testosterone. Once the degree of spermatogenesis or sperm formation required for the male reproductive function has been achieved, like we've filled all the space, remember the Sertoli cells will release inhibin, and this hormone will inhibit the release of FSH until room is present for them to then continue to release FSH, so that we can continue to increase the rate of spermatogenesis. So we've made the sperm now in the testes, and we want to then move it into new areas, okay? Because it can't just remain there in order for it to be functional to create a new individual. So we're going to see that it's going to travel through a series of ducts that are part of the male reproductive system. So we see in the ducts, in the testes, we have the seminiferous tubules. They're curled and twisted, which we saw on previous slide in the picture. You also have straight tubules. They're in the center of the testes. They come after the seminiferous. And then you have the ret testis, which is a network of tubules in the center of each testis that are going to connect to the next area. The next area that these ret testes connect to is the epididymis. The epididymis is a comma-shaped organ behind each testis. Each epididymis contains what we call efferent ducts, which receive the sperm from the ret testes. So we're going to receive the sperm, and this is where they're going to go through their process of maturing. These efferent ducts then empty into the ductus epididymis. The ductus epididymis is a very highly coiled tube with some smooth muscle, and the whole function of the epididymis is to monitor and adjust fluids produced by the seminiferous tubules, okay, to give it the best environment for sperm production. It recycles any damaged spermatozoa, so in this sense it's going to be going through as it passes through, the sperm passes through, they're going to look for any defects or any problems, and if there are ones that are not quite made correctly, they're going to recycle them and send them back. It's kind of like in the chip factory, they'll have people who are quality control and they're looking for the burnt chips and they pull them out. They're not 100% though. Sometimes some defective sperm do get through, just like sometimes you open a bag of chips and you have that burnt chip, but they're going to be watching for anything that comes in that's not produced correctly. We're also going to see that this area stores and protects the spermatozoa until they're mature enough to actually leave the body and do their job. All right, so this is where we're going to see that they finish their maturing is in the epididymis. Once they leave the epididymis, they go into what we call the ductus deferens, which is also known as the vas deferens. They are also called sometimes the seminal ducts. There's 3 layers of smooth muscle here. We see the ductus deferens is going to loop in a series of ways. Okay, so we're going to see that it's going to move up behind the epididymis. So we're going to see it's going to leave the epididymis and move up. It's going to go over the pubic symphysis. So remember, pubic symphysis is the area where the bones come together in the front. So it's going to come over the pubic symphysis. It's going to penetrate into the inguinal canal. Okay, the inguinal canal is going to be, remember, on the sides of kind of in the groin area. It's going to then enter into the pelvic cavity. Once it enters into the pelvic cavity, we're going to see it move over the ureter. Okay, the ureter is going to be what connects the kidney to the bladder. It's going to then move lateral to the urinary bladder, down behind the bladder. So we're going to go down behind the bladder and then empty into the ejaculatory duct. This is the connection between the reproductive system and the urinary system, because the urethra is going to be the structure that urine moves through, but also what semen moves through from the reproductive system. So this is the connection where we see that the urinary system in the males is going to connect with the reproductive system, where the ejaculatory duct combines with the urethra. We also see that there's what we call the spermatic cord. This is going to be a supporting structure of the male reproductive system. With the ductus deferens, it has blood vessels, nerves, and lymphatic vessels. This is also going to be where the cremaster muscle is going to be located. That helps raise or lower the scrotum depending on temperature. The spermatic cord also passes through the inguinal canal as well, with the ductus deferens helping hold them in place. One reason why this is important is because we don't want this long tube as it's going through different areas to kink up, because if it kinks up and we can't move the sperm, it can cause a buildup and cause problems. We then see this leads to the ejaculatory ducts. This is behind the urinary bladder. It's composed of smooth muscle. This is where the duct from the seminal vesicle joins the vas deferens. And we'll talk about what the seminal vesicle does in just a little bit. Then it connects with the male urethra. The male urethra passage is going to be the passageway for both urine and semen. It has 3 components to it. It has the prostatic urethra. This is the most superior portion, and it passes through the prostate gland. Guys, the prostate gland is kind of donut shaped, okay? And so we actually see the urethra is going to pass through there. This is why individuals who have prostate problems and there's swelling of the prostate, it kinks the urethra and it gives them a hard time with urination. We then see there's the membranous urethra. This is the middle portion, and this passes between the pubic rambi. And then we see the spongy penile urethra, which empties to the exterior of the body. So let's talk about some of these vesicles, which are the accessory sex glands, and what they do, okay? Because they're going to be connecting a lot to these different parts of the urethra, and they're going to be adding fluids to the sperm that come through. So the first are the seminal vesicles. They are going to release what we call a very viscous alkaline fluid. When we say alkaline, guys, alkaline is going to be more basic with a higher pH, and this is 60% of the total volume of semen. Now, one reason why we need an alkaline fluid is because urine is normally very acidic, and so this fluid is going to help neutralize the acidity of the urethra, since urine comes through there as well. It also contains fructose, which is a sugar. This is for energy for the sperm, because the sperm do contain mitochondria, which need to be able to move that tail for them to swim. It has prostaglandins, which stimulate smooth muscle contractions, and it also has clotting proteins. There are clotting proteins located here called fibrinogen, so this is why after semen has been ejaculated, it starts to kind of clot up and clump up, and the whole purpose of that is to help protect the male sperm for a while, because once inside the female's body, it's a very hostile environment for the sperm. The sperm only has 3 days to find the egg before the female's body kills and destroys the sperm. The alkalinity will not only neutralize the acid in the male urethra from the urine, but it also will help with the female reproductive tract as well, help with protection. The prostate gland is the second gland. This is a small donut-shaped gland. It's below the bladder, and it surrounds the prostatic urethra. It's going to produce 25% of the ejaculatory volume of the semen. The prostatic fluid is a milky, slightly acidic solution, and it contains citric acid. Citric acid is also for energy. If you'll recall, cellular respiration and the whole idea of moving and changing glucose into ATP, there was a cycle called the Krebs cycle, also known as the citric acid cycle. So this citric acid can go straight into that in the mitochondria and make more energy for the sperm cells. It also has acid phosphatase and what we call proteolytic enzymes. All of these are, of course, going to help again with protection and giving the sperm the best chance it can to potentially find the egg. The last one's called the bulbourethra or Cowper's gland. This is a pea-sized gland, so it's small. It's below the prostate, and its duct opens into the spongy urethra. It secretes also protective alkaline mucus. Again, this decreases sperm damage in the urethra, and the reason that it's released here is because when that sperm gets ejaculated, it's going to happen very quickly. So it's going to move very fast through the urethra, and so this is a mucus type structure to help it pass quickly to decrease friction so that we don't see damage of the sperm cells in the process. All right, so this brings us to the penis. The penis has 3 kind of main parts to it we want to discuss. The first is the root. This is the proximal portion. It's the portion that connects to the body. The bulb of the penis plus what we call the cruard. This is going to attach the penis to the pubic ramie. The root is supported by skeletal muscles, and this skeletal muscle and tissue is going to help with ejaculation. We also see that there's the body. The body contains blood sinuses, so there's like openings in this area that can collect blood. We also see that there's arteries and veins. This is also called the spongy urethra because of the fact that it has these holes in it. During sexual excitation, it causes dilation of the penile arteries, so they dilate, which then causes fluid to leak out, and expansion of these blood sinuses. This is a parasympathetic response, so the individual needs to be relaxed in order for this to take place, the whole rest and digest. All this blood compresses the veins, though, so it compresses and pushes on the veins so that they cannot drain the blood. Since they cannot drain the blood gets trapped, and this is what causes an erection. The glans penis is the most distal portion. It has what we call the prepuce, which is the foreskin on it. This is a loosely fitting skin that covers this part of the penis. Now, this can be removed. A lot of times when it's removed, we call this circumcision. It's a surgical removal of this part. The main thing is a lot of times it's for hygiene issues. It's also just like a normal custom in some countries in order to do this. it happens when the individual is about 8 days old. That way that they don't really remember that it happened. It's kind of like when I got both my girls' ears pierced when they were really young, so they don't remember the pain that comes along with it versus when they're older. However, if this foreskin is still present as an adult, it can still be removed through circumcision. It's just going to be more painful and you will definitely remember it. All right, so this is what we're talking about for the male reproductive system. So now we're going to move on into the female reproductive system. Now, with the female reproductive system, they produce the sex hormones and also the functional gametes, just like we see with the males. However, it's also going to protect and support a developing embryo, and it's going to nourish the newborn infant. Okay, so it has a few more jobs than what we see with the males. Overview of the female reproductive system: we have the ovaries, which again are the gonads. They're the part that's going to produce the gametes. The uterine tubes, which are also known as the fallopian tubes, are also known as the oviducts. We also see the uterus, the vagina. So we also see the vulva and the mammary glands. So let's start with the ovaries first. The ovaries are located in the upper pelvic cavity on either side of the uterus. They're held in place by a series of ligaments. Their size and shape is kind of like an unshelled almond. So if you looked at how big an almond is when it's not in its shell, that's about the size of each ovary. Their whole purpose is to produce secondary oocytes. That's a more mature oocyte, which is an egg, to be released. They release one. That's what ovulation is each month. Again, each ovary, though, can release an egg at a time, so there could be 2 released at a time normally. Again, if certain drugs are present or genetics can play a role where more eggs are released at the same time, it can occur. They also secrete the female hormones estrogen, progesterone, inhibin, and relaxin. We then see the uterine or fallopian tubes. Again, also they're known as the oviducts. These extend laterally from the uterus. They have an area that's called the infundulum. This is an opening or funnel-shaped kind of portion. It's close to the ovary, and it has little finger-like extensions called the fimbriae. These finger-like extensions, the whole point is to sweep or pull the secondary oocyte, the egg, into the tube. I was talking about how they kind of look like a sea anemone, okay, where they're pulling the egg in. Once they pull the egg in, the oviduct contains smooth muscle to propel the ovum or egg towards the uterus. Some of the cells inside of the fallopian tubes are ciliated. Remember, they have the small hair-like extensions, and they help move the ovum forward. The ampulla is the lateral 2/3 of the tube, and it's the widest and longest point, and this is where fertilization is actually going to occur. The fallopian tube is where it occurs, but the ampulla, the longer portion, is where it's going to take place. The isthmus is the medial narrow part of the tube itself. This brings us to the uterus. The uterus is the size and shape of an inverted pear. Inverted means it's an upside down pear. It's superior to the bladder, so it's right above the bladder. We also see that it has a couple of different structures. The first is the fundus. This is the superior dome-shaped portion of the uterus. The body is the central or tapering portion, and then the cervix is the most inferior narrow part. This is the area that also opens up into the vagina. So the cervical canal is only about 1 centimeter long. It's not a very long area, but this is also the area that has to dilate and open during labor and delivery, up to 10 centimeters. There is an internal opening. This opening is into the cervix. It's the cervix opening into the uterine cavity, whereas the external opening is the opening of the cervix into the vagina. The uterus is held into place by several ligaments that help hold it where it needs to be. Now, before we continue on to look at structures, I want to take a minute and look at the histology or the tissue of the uterus, because this is kind of important. We see that there's what we call the perimetrium. This is the outer layer. This is part of the visceral peritoneum. This is going to be covering part of the uterus is the peritoneum. Then you have the myometrium. This is the middle layer. This has 3 layers of smooth muscle. This is the part that's going to contract and all during contractions, or even during that cause cramps during periods. Then you have the endometrium. This is the innermost layer. This contains many blood vessels. It's very highly vascular. And the whole point of this is there's 2 layers of the endometrium. There's what we call the stratum functionalis. This is the area that lines the uterine cavity, and it sheds each month. This is the part that's going to be the shedding of the blood and the tissue each month if implantation of a fertilized egg does not take place. The stratum basalis is the bottom layer of this. It's a deeper and it's a permanent layer. It's going to replace the stratum functionalis each month. All right, so when we talk about the base layer, the basalis, it's not going to leave. It's going to then recreate the next month the stratum functionalis, that layer, in order to allow for a potential implantation the next month. Now, this serves as part of the pathway for sperm being deposited into the vagina. It's also the site of implantation of the fertilized egg. This is where the development of the fetus will occur during pregnancy. All right, so once the sperm is deposited in the vagina, it moves up through the cervix to the uterus, and then it's got to decide which direction to go in the fallopian tubes, to the left or to the right, in order to fertilize the egg that has been released. This then brings us to the vagina. This is located between the urinary bladder and the rectum. It is directed a little superiorly and posteriorly. We'll see that it has an area called the fornix. This is the vault which surrounds the vagina-cervix junction. The muscularis is a double layer of smooth muscle, and it's very elastic here, and this is important because the elastic allows it to stretch and then hopefully go back after childbirth. The vaginal orifice may be partially covered with a thin fold of what we call mucous membrane. That's what that MMB stands for, is mucous membrane, and that's known as the hymen. The vagina serves as a passageway for menstrual flow. It also is going to receive the sperm, and it also will form the birth canal during labor and delivery. All right, so the vuvia is the external female genitalia. When we look at this, we're going to see that there's a number of different parts to the external female genitalia, as well as we saw with the males. There's what we call the mons pubis. This is a mound of adipose tissue. This adipose or fat tissue is there to help cushion the pubic symphysis. Okay, so it cushions the pubic symphysis, which was the area where the hip bones come together in the front. We see that there's the labia majora. This is the larger area. This is made of adipose tissue, sebaceous glands, and sudoriferous glands. Labia, guys, means lips, and then majora means major. This is the homologous structure to the scrotum. So during embryonic development, it comes from the same kind of origin as the scrotum does. We see the labia minora, which means smaller. Okay, it's medial to the labia, and there's a typo here. This is medial to the labia majora. This area is hairless. It only has a little bit of adipose tissue and sudoriferous glands, but it has many sebaceous glands. And again, these glands are there for secretion, for just the normal pHs and things like that we see in a female, but they also will play a role during sexual excitement as well, what we see in males. The next area you have is the clitoris. It's a small circular mass of erectile tissue and nerves. This again is homologous to the penis. This is the erectile tissue. It also has sometimes what we call the prepuce or foreskin. This is the point where the labia minora joins and covers the clitoris. The glans is the exposed portion of the clitoris, and the clitoris will enlarge during sexual arousal. It'll get larger. The vestibule is the area between the labia minora. This is going to lead to the vaginal orifice just posterior to the urethral orifice. We also then see the external urethral orifice, which is between the vaginal orifice and the clitoris. Okay, so there's going to be some different kind of openings and spaces between those openings, since the female reproductive system is separate from the urinary system. So just like in males, we see that there are also going to be glands in females that are important. There's what we call the periurethral or Skene's gland. This is on either side of the urethral orifice. It's homologous to the prostate gland, and it will secrete mucus. Again, this is going to be important for sexual intercourse. There's the greater vestibular, what we call Bartholin's glands. These are on either side inside of the vaginal orifice. They're going to be homologous to the Cowper's glands, and they secrete mucus for lubrication, again during sexual arousal and for intercourse. Now, one thing that is different that we see in females versus males is how many gametes get made each day / month. We saw in males we can create from one stem cell 4 sperm cells. In females, it's not the same. And also, when we look at this with females, they're only going to produce 1 to maybe 2 a month, whereas males make about 500 million sperm a day. So with oogenesis, which is the formation of eggs in follicular development, we see oogenesis occurs in the ovaries. It's a formation of a single haploid secondary oocyte, and this comes from the oogonia. There's going to be the process of meiosis 1 and meiosis 2, and then we're going to see that it actually will mature, just like we saw how sperm matures in the epididymis. The follicle cells surrounding the oocyte are also undergoing developmental changes as well. There's going to be a sequence of follicular changes that take place, and with these follicular changes, this is what's going to lead to the actual rupture of that follicle and release of the egg. Okay, and so these follicles have to go through these changes in order to allow for the maturing of that egg to be released, then to be potentially fertilized through the fallopian tubes. So when we look at the female reproductive cycle, there's two areas that we have to kind of focus in on. There's the ovarian cycle, and this is the maturing of the egg each month where it gets released. And then you also have the uterine, or also known as the menstrual cycle, and this involves the changes that take place in the uterus, and those changes are going to be directly related to whether that egg got fertilized or not each month. Now, the ovarian and uterine cycles are going to be controlled mostly by hormones. So there's going to be a big hormone regulation of these female reproductive cycles. Of course, it's controlled by the gonadotropic releasing hormone from the hypothalamus. This is going to stimulate the release of the FSH and LH by the anterior pituitary gland. Remember, the FSH is the development of the ovarian follicle and the secretion of estrogen by the ovaries, whereas the LH is going to further develop that ovarian follicle. Remember those steps we just kind of looked at last slide. It's going to allow that follicle to continue to develop until ovulation actually takes place. And then the secretion of estrogens and progesterones by the ovaries as well. Now, estrogens, guys, have several important functions. Of course, it's the development and maintenance of the female reproductive structures, but also secondary sex characteristics like we see with the voice being not as deep. We also see the fat distribution of body hair in certain areas as well, and the development of breasts. We see increased protein anabolism and the building of strong bones. Estrogen actually helps build strong bones. This is why when women go through menopause and they stop producing estrogen, we start to see a higher rise in osteoporosis, because they don't have the estrogen to help them deposit the calcium into their bones. We also see that estrogens help lower blood cholesterol as well. Moderate levels of estrogen in the blood inhibit the release of gonadotropic releasing hormone by the hypothalamus, and also secretion of LH and FSH by the anterior pituitary gland. And so when the ovaries are releasing this estrogen, it's letting them know that, hey, we're doing our process. Let's wait and see what happens before we start developing another egg in the ovaries. Progesterone is a different hormone, and it works with estrogen to prepare the endometrium for implantation, the innermost layer of the uterus. It also is going to help the mammary glands get ready for milk synthesis and the formation of milk if pregnancy does occur. Relaxin is another hormone that is released. It's produced monthly to relax the uterus by inhibiting contractions. This makes it easier for a fertilized ovum to implant into the uterus itself. During pregnancy, relaxin is going to relax the pubic symphysis and also help the dilating of the cervix to help facilitate the delivery of the baby. Inhibin is going to inhibit the secretion of FSH and gonadotropic releasing hormone. It's going to do these first because the LH is going to help with the production of the estrogen and progesterone, and so we don't want to get rid of the LH completely, but it still does decrease it. But it decreases and inhibits the FSH and the gonadotropic releasing hormone to a greater degree, because they're the ones that start the process of making more follicles and starting the process of releasing more eggs, and we don't want that to take place if pregnancy has occurred. Now, the female reproductive cycle may be divided into 4 main phases. The menstrual cycle, or also known as menstruation, is the first 5 days of the cycle. This is where the small secondary follicles in each ovary begin to develop. So that's what's happening in the ovarian side, okay? In the uterine side, we see that the stratum functionalis layer of the endometrium is shed. It's discharged. It's sent out of the body. And this is a series of tissue fluid, mucus, and epithelial cells with the blood. Now, the second phase is called the pre-ovulatory phase, also known as the proliferative phase. This is a more variable in length depending on the woman than the other phases. It could last between 6 to 13 days. It's lasting from day 6 to 13 if the woman's on a 28-day cycle. The primary follicles inside of the ovary start to develop into secondary follicles and then into a single secondary follicle. Occasionally, more than one can happen, and this develops into what we call the vesicular ovarian or the Grafton follicle. This is going to be the mature follicle, which is going to get ready to rupture in the next stage. So this follicle produces a bulge on the surface of the ovary. The dominant follicle continues to increase its estrogen production under the influence of the increased levels of the LH. Okay, so now again, this is going to be happening in the ovaries. On the uterus side, though, during this phase, the endometrial will start to repair itself. We're going to start developing, because we just shed it, we're going to start developing that layer and thickening it to get it ready for potential implantation now that the egg is almost ready to be released. Stage number 3 is actually known as ovulation. This is the rupture of the vesicular ovarian follicle. This releases the egg, the secondary oocyte, into the pelvic cavity. This usually occurs right in the middle of the cycle. So if it's a 28-day cycle, this is going to occur on day 14. On this day, there are going to be super high levels of estrogen during the last part of the pre-ovulatory phase. This exerts a positive feedback on the LH, so it's going to release even more LH. The gonadotropic releasing hormone promotes the release of the FSH and more LH by the anterior pituitary gland. The LH brings on the surge that causes the ovulation or the rupture to take place. Now, following ovulation, the vesicular ovarian follicle will collapse, okay? And so it ruptures like a balloon and then it collapses kind of back down. When it collapses, it actually forms a clot. And this is why some women can talk about how they actually feel the ovulation. Some of them even have pain when they ovulate because it actually does rupture. This becomes what we call the corpus hemorrhagicum. Now, when we look at the first part of this word, hemorrhage, it means that there's a blood clot there. Now, stimulated by the luteinizing hormone, the LH, this is going to convert it into what we call the corpus luteum. It's going to now start secreting lots of estrogen and progesterone at this point. The post-ovulatory phase is the most consistent in duration or time, and it lasts between days 15 to 28 if they're on a 28-day cycle. And this is the time between ovulation and the onset of the next menstrual period. So with reference to the ovaries, this phase of the cycle is also called the luteal phase, during which both estrogen and progesterone are being secreted in large amounts by that corpus luteum. Now, if fertilization and implantation does not occur, let's say that the egg does not get fertilized, it does not get implanted, we see that there's a decreased secretion of the progesterone and estrogens. This initiates another menstrual phase. So it allows us to then go and start back over on day 1, where the uterine cycle then is going to start with menstruation, the removal of the endometrium, and then the ovarian cycle is going to start over with creating a new follicle to then release a new egg the next month. Now, if fertilization and implantation do occur, the corpus luteum is going to be maintained by the human chorionic gonadotropin, that HCG, from the developing placenta. This is going to then continue the secretions of the levels of estrogen and progesterone in order to support the pregnancy. And then also it's going to be used with breast development for the lactation. So if the estrogen and progesterone levels stay high because the corpus luteum is continuing to release them, then that normally lets the body know that implantation has taken place with a fertilized egg. And we don't go into the next menstrual cycle. So if you take a look at this with the female reproductive cycle, I took some pictures and kind of put them one on top of each other so you can see kind of what's happening. Up here at the top, you can see that you have the hypothalamus and the pituitary gland, which plays a role releasing certain hormones. It shows you then the ovarian cycle and what's happening inside the ovaries. And then it shows you the uterine or menstrual cycle, what's happening inside the uterus. It also shows you the menstrual phase, the pre-ovulatory phase, the ovulation, and the post-ovulatory phase down there at the bottom, and it gives you the days. And again, this is on if the woman's on a 28-day cycle, and the cycle can be different for each woman. Sometimes it's less than 28 days, sometimes it's more than 28 days. All right, but this just kind of gives you an idea. Now, while all this is occurring, it's showing you that hormones play a role in this by giving you the different arrows, whether the green is the gonadotropic releasing hormone, the blue is the FSH, and the orange is the LH. But I also want to show you another picture of what happens to the hormones throughout this 28-day cycle. If we look here, you're going to notice they're represented by the different colors. You can see the days at the bottom. Your FSH levels stay pretty consistent, except for they peak around that day 12, the end of the pre-ovulatory phase. LH is going to stay pretty consistent until that point as well, but you see a huge spike in LH at about day 11 to 12. You also see estrogens and progesterones start to spike. And guys, if you look at this, this is like a roller coaster. In females, they have a roller coaster of hormones that are happening every month. And I'm not trying to excuse away their behavior and things like that, but they actually do have a rush of different types of hormones at different times, which can affect their behavior and potentially cause mood swings and things like that take place. Now, with the uterine cycle, guys, there's a couple of terms I want to talk about. Menarche is the first uterine cycle, so when puberty actually begins. This happens between ages 10 and 12. It's actually getting to be younger. The average is 10 to 12. The average used to be 14 to 16. So we're starting to see it go down, and we have actually even seen 8-year-olds who have started this cycle. A lot of times, guys, it depends on body fat, the amount of body fat that's present inside the female. Once they reach a certain body fat index or body mass index, it then causes the body to release the hormones needed to start the process. Menopause, on the other hand, is the termination or the last time the uterine cycle takes place. This can happen anywhere between age 45 and 55, and that's when they go through menopause and they stop producing these hormones. Amenorrhea is whenever we see that there is a stop in the menstrual cycle. This can happen two ways. The first is primary amenorrhea. This is a failure to even initiate menses. You never start your menarche. Now, this happens a lot of times in individuals who never reach that body fat index. And one of the best examples are kind of like gymnasts. If you look at gymnasts, a lot of times that they look, even though their age is like 22, they look like they're very young, like their body looks like they're a 12-year-old except for all the muscle. Part of this is because a lot of times, because they are so fit and their body fat is so low, they actually never start their menstrual cycle until they get older. Now, this can create a problem because remember I told you estrogen is really important in keeping your bones strong, and so if they're not producing that estrogen because they're not having their normal cycle, this can actually make their bones weak as well. Transient secondary amenorrhea is whenever there's an interruption with the cycle for 6 months or more. So they've had a normal menstrual cycle in the past, but then there's been at least 6 months or longer that they have not had this. This could be caused by physical stress on the body. There's actually an issue, or it could also be caused by emotional stress on the body as well. So this just gives you an idea when we're looking at some terms when it comes to the uterine cycle in females. Now, when we talk about sexual function, another thing that always comes up is sexually transmitted diseases or STDs. I believe most of the time these are now called sexually transmitted infections, STIs though. They are transferred by sexual intercourse. They can be bacterial infections, viral infections, as well as fungal infections. There's a lot of different ones. They are talked about in your book. Examples are pelvic inflammatory disease, which is called PID. AIDS can be transmitted sexually, and that's through the HIV virus. Gonorrhea, syphilis, herpes, genital warts, and this is just to name a few. You can take like a whole class that talks about sexually transmitted diseases because there are a lot of them. But this is just to give you an idea that they are there and they are going to be transmitted through sexual intercourse. Again, at the end of this chapter, you also have how reproductive system does help with homeostasis in the body. You also have a section that is about when there is issues with the reproductive system. So take a look at those at the end of the chapter as well. Again, if you have any questions or concerns, please feel free to contact me, and happy studies.